Perfect. Yeah. So this is the fentanyl lecture, everyone's favorite thing. I have no financial disclosures, and the learning objectives, basically describe fentanyl, why it can be difficult to treat, understand general trends in opioid deaths, basic treatments for opioid use disorder, and describe different methods for kind of buprenorphine induction. And we can go on to the next slide. So, what is fentanyl? It is a synthetic opioid. It means that it is made in a lab, does not occur naturally in nature. It is also an extremely potent molecule. There are, depending on which paper you read, they rate it anywhere from 70 to 120 times more potent than morphine. I just kind of stuck with the middle, which seems to be the general consensus, about 100 times more potent. So, kind of a scary molecule if you get like higher doses of it than you're expecting. It's also extremely lipophilic. So when it is ingested, however that is, whether orally, smoked, whatever the case may be, really loves the fatty body tissues, which we're going to discuss a little bit later, and why that is a problem both for how addictive it can be and overall treatment. Next slide. So why do we care? Well, we're all here, so we all know about the kind of general trend in overdose deaths involving opioids. You can kind of see the line here. This is the most recent one I was able to get actually from the NIH or the NIDA website. It only went to 2022 for some reason, but you can see line continuously goes up there. So, back in the early 2000s, significantly less than 20,000 patients. And then we get up to 2022, we're at 81,800 overdose deaths, which is quite an incredible number. Recently published data that was coming from the CDC said that we might have potentially had a slight decrease. In 2023, they were putting it at about 81,000 even potential opioid deaths. But then I saw other articles which rated it as potentially more. So I think we're still waiting for kind of a finalized tally on that, basically. Um, and that is about what I have to say about the opioid deaths. So we can move on to the next slide there. All right, and this is the graph, which anyone who has probably ever been in an opioid lecture has seen before. Basically, it shows that prior to really that 2015, 2016 stage, the overdose deaths when it came to opioids, primarily heroin related right there. You can see that blue line. And then the kind of synthetic opioids, of which most of it is fentanyl, really took off. And you can see the deaths from the heroin line basically just kind of crashing because it's pretty difficult to find anymore. Everything's just heroin. Let me see here. Basically, I was kind of looking through the DEA website, and from their most recent kind of statistics of all the kind of like basically black market kind of pills that they were testing from the street, about 42% of them contain at least 2 milligrams or more of fentanyl, which is a pretty significant number because that happens to be about the dose that an opioid naive individual will overdose and potentially die at. So pretty scary stuff when there is that much fentanyl just kind of floating around there. Why is it on the rise as much? Been a lot of theories. The biggest one seems to be that it's super easy to make. A little bit goes a long way, so you don't have to traffic the kilos and kilos and kilos of it like you would with heroin. A few small bricks of fentanyl can adulterate a huge supply. So yeah, it's in everything, and we need to have a good idea of how to combat it effectively. So we can move on to the next slide. So it's fentanyl. We're going to talk fentanyl some more. I know I talked and said that it's a highly lipophilic molecule. So let's kind of talk about what that means. Basically, it dissolves and moves very easily into fat-rich areas of the body. And this poses a problem for a couple of reasons. One, the brain is just full of lipids, like all those myelin sheaths, everything. It is a fat-rich environment. Blood-brain barrier is not really able to keep it out because the blood-brain barrier is made of cells, which have cell membranes, which are made of fat. So it just kind of cruises right along through there, gets into the brain, causes that very quick euphoria as it just kind of spreads all over the place. So yeah, hard to kind of keep out of the brain, very easy to get into it. So not great. And then the second problem which poses a little bit more of a difficulty for us when we're trying to treat it, is that same lipophilic nature. So the body has fat stores in it. And in individuals who are using increasingly larger and larger amounts of fentanyl, you have more of it floating around. It has the ability to diffuse out into the body fats. And then if an individual stops using fentanyl, it's basically through the power of diffusion and chemistry, it starts to leak its way back into the bloodstream, makes its way into the brain, and this can lead to prolonged periods of withdrawal, prolonged periods of basically testing positive for fentanyl on urine drug screens. Found a recent study, it was relatively small, but just kind of tested the individuals who were coming into the rehabilitation center. And they'd found that in this cohort of individuals, those who habitually used fentanyl, it would take up to like 13 days for their urine to kind of turn negative compared to the shorter acting opioids, which tend to get out of the system in about 2 to 4 days. This implies that there's likely a relatively significant amount of fentanyl kind of circulating around the body. And if it's doing that, it is then activating the opioid receptors in the brain and kind of leading to problems, basically. Um, and this then leads to the potential problem number three of precipitated withdrawal, which is kind of the big fear when we're looking to treat something like this. And we will talk about that in a minute. So we can move on to the next slide. So right off the back, let's just talk about kind of treatment options here. So, there's, I would say, four main ways that we could go about this. You have the cold turkey method, which is probably not recommended, and the literature supports this, where you have the patient just stop, they withdraw, and maybe you give them some medications to make the withdrawal a little bit better for them, but it sucks tremendously for them while they're going through this. Also, does not tend to lead to significant long-term abstinence from fentanyl or opioid use. And I would say the threat of withdrawal often keeps patients using opioids because it's so terrible that they just don't want to go through it. It can be kind of a barrier to treatment for something like this. So overall, cold turkey, not a great option. Uh, Next up, we have the naltrexone or the long-acting injection Vivitrol. I've heard this touted as kind of like the drug-free option to treating opioid use disorder. They were kind of saying this is going to be the next big thing. It'll replace like buprenorphine and methadone. And what Vivitrol does, or naltrexone, is it goes in, it actually blocks up those opioid receptors. So in theory, you use an opioid, it doesn't really affect you. And through kind of like the extinction model, you don't get a high from it. And you kind of say, well, what's the point of this? And then you stop using it. What the studies have really actually shown is it doesn't really provide any like significant mortality benefits as far as kind of stopping future overdoses, doesn't keep patients in treatment all that well. And it definitely doesn't do anything to reduce the psychological cravings and suffering that individuals with opioid use disorder have. Not necessarily a great option. It is okay for the right kind of patient. I have treated a patient with it before, and they seem to do well. So, really, you just have to find that right individual. Next up, we're getting into the more kind of like evidence-based that show that it works pretty well. We have the buprenorphine, which is, Suboxone's the brand name for that, contains buprenorphine and naloxone. Buprenorphine is the actual active ingredient we're using to treat the opioid use disorder. It's a partial agonist, so it goes in, it activates those receptors, just not as much as, say, a full agonist like methadone or fentanyl, which is a full agonist will do. And what's kind of nice about it is it does protect the patient a little bit once you get them kind of stable on this, because buprenorphine binds quite tightly to those opioid receptors, and it can be a bit difficult to kick off. I think one study I saw said that it can bind for up to like 40 minutes at a time or something ridiculous. And most molecules in the body, they're kind of like bouncing on and off of receptors like multiple times a second. So that's pretty significant if that is in fact how it works. It's considered basically one of the gold standard treatments next to methadone. It's convenient in that you can take it at home. You don't have to have daily dosing at a methadone clinic, at least until you get to the point of having take homes. Relatively good option, easy to prescribe in the outpatient setting, say at a primary care office, like where I am. Let's see here. And then the last option, which is the oldie but a goodie, is the methadone. That is kind of the original treatment for opioid use disorder outside of using full strength agonists, but or other ones, but that was made illegal by a number of federal laws. And basically, it is a full agonist opioid. It has a long half-life, and it binds directly to those opioid receptors, so it kind of relieves that craving and withdrawal effects when you get a patient on methadone, and still very, very widely used today. And then we can move on to the next slide. So I mentioned that precipitated withdrawal a bit earlier. What about it? So really seemed to be kind of, came into focus in around 2009 in the studies when fentanyl was starting to kind of come onto the scene. Basically with that kind of lipophilic nature that I was talking about, there was this huge concern that, there's still going to be enough fentanyl floating around in the system. You're going to give a patient, say, buprenorphine, which would kick those molecules off, and it's going to cause them to go into precipitated withdrawal. And then what do you do from there? A lot of subsequent studies show that this fear seems to be a bit overblown, provided that you do things correctly. It is still, very possible that you can precipitate withdrawal, but, from a few different studies, one of which I'll cite by, I can't pronounce the name, study, Onofrio. Basically, they did a study in the emergency department, 1,200 presentations of patients who are testing positive for fentanyl, and who did receive a buprenorphine induction that ranged anywhere from 8 milligrams to 16, depending on what their withdrawal score was. They had a precipitated withdrawal rate of less than 1%. So really not as big of a concern as they kind of made it out to be, but certainly something to be aware of. And with this study, they did kind of follow up with the patients, 24 hours after discharge, and didn't really see all that much of an increase in any kind of withdrawal symptoms. So it seemed that they were treated pretty well with buprenorphine. Yeah, so we can move on to the next slide there. All right, buprenorphine strategies. So how do we kind of go about starting buprenorphine on a patient who has been using fentanyl or is testing positive for fentanyl, even if they weren't intentionally trying to use it, just because it's in everything now. And there's kind of two fundamental ideas in the fentanyl kind of age of how we look to start buprenorphine. There's the high dose and the low dose induction. High dose seems to be popular in the emergency departments. I don't think I've seen it done much in the outpatient setting, but basically the idea is you just flood those receptors with buprenorphine. The studies that were being done, they were taken anywhere from 16 to 24 milligrams in a single dose if they were in withdrawal, provided they had a significant enough COWS score. And a lot of these studies were finding that it appeared to be safe. They weren't finding like oversedation. They weren't finding increased risks of, precipitated withdrawal or anything like that. And patients were overall treated pretty well. Has the benefit of potentially just kind of stopping that withdrawal sensation very quickly, which in theory would help patients kind of remain in treatment longer and just get them on the path to where they're interested in going with their lives. And then the second is the low dose method. And basically, it is the exact opposite. Rather than starting with a big dose, you start off with a very low dose, usually around the 0.5 milligrams of buprenorphine. And then you work your way up over the course of a week or so to get to 8 to 16 milligrams daily, depending on kind of patient symptomatology. And the idea with that is we're actually slowly replacing the fentanyl from the opioid receptors. So you do such a small dose, you get a little bit of those buprenorphine molecules floating around, binding to some receptors, starting to stimulate them a little bit, but not enough to kick off a bunch of fentanyl molecules and potentially send a patient into precipitated withdrawal. And then just as you kind of continue to build it up, the body's getting used to having this partial agonist on there. It's not necessarily kind of going through withdrawal anymore. And you get to the point where you get them up to their working dose and they're kind of off to the races at that point. Next slide. And then what about methadone? Still like a super important player in this game. I know, for a little while there, people were kind of wondering if maybe buprenorphine would really kind of like, slow down the need for something like methadone. But with fentanyl being what fentanyl is, we're seeing it become, or not become, stay extremely relevant and useful. The only kind of bummers with it is it can be a little bit more difficult for patients to utilize because we do have specific federal regulations we have to follow. You have to do daily dosing for the first while before you can get take homes. Like it can be a little bit burdensome, but it can be very useful for patients. There are definitely some researchers out there who are calling for changes to federal guidelines as far as kind of where you start a patient with methadone. Because there are currently caps on how much you can prescribe a patient in the first day. And please forgive me, anyone who works at a methadone clinic. I forgot if it was 30 or 40 milligrams. But basically,
40.
40? Perfect. All right. But basically, 40 milligrams for patients who are using large amounts of fentanyl is not going to cut it as far as really kind of cutting down on their withdrawal symptoms and, keeping them from going back to using fentanyl to kind of relieve their symptomatology. So, there is a clinic currently that, and I should also mention the current like guidelines that we aren't necessarily held to kind of like as far as federal law or anything are saying maybe go up for anywhere from 1 to 5 kind of milligrams of methadone over the course of like 3 to 5 days or so. And that's pretty slow for someone who is suffering. So there are a few clinics out there that are experimenting with more, I guess we could call a rapid induction of methadone where they start off with like a 40 milligram dose on day one. They go up to 60 milligrams on day two. They go up to 80 milligrams on day three, usually for their very heavy users of fentanyl, like people who are reporting close to like a gram a day or something like that. And at least with the preliminary studies, seems to be relatively useful as far as getting them feeling better quicker, keeping them in treatment longer, and getting them kind of to that place in life that they're hoping to be. So all that to say, methadone still a very excellent option for treating patients with even those using fentanyl. And yeah, and I think with that, I cruised through that a little faster than I meant to, so I apologize for that. But I had a few pages of sources there if anyone cares to look at them.
Thank you. It just gives us enough time for questions. So, does anyone have any questions? Luke, and then Jake.
Yeah. Yeah. Thank you. That was a great presentation. And I was wondering, do you have any information about post-acute withdrawal symptoms from fentanyl? Seems like we have quite a few patients that are on methadone for treatment, and they will report even if they stop using fentanyl, withdrawal symptoms for weeks. And I
Oh,
don't know if it's addictive behaviors that are looking to go up on methadone, or if these are really post-acute withdrawal symptoms, or yeah, so I was wondering if you have any comments about that.
yeah, so at least in my experience when I was kind of working at Raise the Bottom during my fellowship, we would definitely see patients as we were titrating them up that they were still complaining of, those withdrawal symptoms, albeit at a lesser dose. And oftentimes we just kind of kept going a bit, especially on our patients with, fentanyl on board. And it did seem to kind of alleviate the problem. They described it kind of less and less once they got to usually kind of those higher doses. I think I was seeing a decent amount in the uh kind of 140, 160 milligram kind of range before they were truly feeling like good about things. Whether or not that is a known syndrome, I'm not super familiar with. Someone else might have some extra information on that, but that's just kind of the personal experience I've had with it.
In terms of dosing, I'm at Raise the Bottom now, Andrew, and there's patients there on 300 milligrams of
Ooh,
methadone a day, all
that's
because of
exciting.
fentanyl.
That
Yep.
is higher than I had ever seen. So that's incredible.
Insane. Yeah, it's a total paradigm shift with
Hmm.
fentanyl.
Oh, absolutely.
So Andrew, I wanted to bring up two things that are one of them is kind of a newer concept, and the other is sort of a dilemma that we deal with a lot in this situation, especially when we're doing the low dose induction. So the first question is, have you come across anything where they're just starting right out with sublocade, um, right from methadone to sublocade? I know there's some thought about doing that. The other question I have is, so you do low dose induction, right? And typically we leave people on their full mu agonist, whatever that is. We leave them on it while we're doing that induction. So in this case, we're saying, well, um, we're not crazy about this, but if nothing, if you're not open to any other options, then you got to keep taking fentanyl off the street, right? So I mean, this is a dilemma, medical legally that comes up, and I mean that the way I deal with it is, um, uh, if they're not open to any other options, then I don't condone it, but I clearly document that in the chart. And yeah, they're going to continue to use their fentanyl on the street, and I'm going to do a low dose induction. Um, I guess if they have chronic pain, you could give them another full mu agonist but that's risky. If they
Mhm.
mix that long acting full mu agonist with, or even a short, with fentanyl. So I just wanted people to be aware that this is a dilemma that comes up, and you have to do really good documentation, and also to get your thoughts on this, how you handle it.
Yeah, so to address kind of that second point, like that is the dilemma, isn't it? We know that the low dose induction is not really going to cut it as far as kind of getting rid of their symptoms. And when I do this, a lot of my patients do continue to use, I will obviously provide the recommendation and offer, medications to help out with withdrawal and all that, if they're willing to come off of it. But, if they're not, they are their own person. They can make their own decisions, and I'm not going to withhold care just because they're going to continue using fentanyl to help alleviate their symptoms. But as you mentioned, we just make sure that we document it well. And I think that, effectively kind of puts you in the clear. I think you've done your due diligence as a doctor at that point. So that seems reasonable to me. Also not my favorite, but it is what it is. As far as transitioning, I'm assuming just you're talking going from methadone to something like Suboxone or Sublocade or something like, well, I guess it'd just be Sublocade. You couldn't really do.
No, no, transitioning from someone's on from fentanyl to sublocade.
Oh,
Uh,
fentanyl to Sublocade.
figure it out. I think some people are playing around with that now, and I'm just wondering if you come across anything.
Gotcha. I mean, I haven't heard about it myself. I can, I guess, see the point. I know there were a number of patients when I was at the VA where we would kind of do their UDS, kind of the very in-depth testing of it. And even though they were taking their Suboxone correctly every single time, we would still see evidence of naloxone present in their system. So ideally, you're not supposed to absorb any of it, but this is not the ideal world. So I guess I could see that potentially being a way to ward off any additional chance of withdrawal, but I haven't read any specific papers on it.
Yeah, I mean, of course, with sublocade, you're not getting any naloxone, right? It's just
Exactly, exactly. So I could see that kind of being their thought process.
I mean, typically when we're doing a low dose induction, let's say we're going from methadone to, we're doing a low dose induction. We usually continue the same dose of methadone
Mhm.
during that like 7 days or so. But fentanyl, you know, boy, can we get away with not continuing the same dose of fentanyl because it's so lipophilic and maybe there's a bunch of it leaking
Mhm.
out? So, but it is tough to, when someone's on a high dose of fentanyl to go to point 0.5 of bupe.
Oh yeah.
Um, I mean, if you can get away with it, great. If they do okay, maybe give them some adjunctive meds for withdrawal. But like you're saying, there's probably some patients that they're not gonna do that. They're gonna continue
Mhm.
taking the fentanyl. Just
Yeah,
good
yeah,
documentation.
exactly.
Andrew, I have a quick question regarding the macro dosing like
Mhm.
induction. When you're comparing that to like the micro dosing, my guess is you're going to be looking at like you're going to want higher scores for the like a cow score before like attempting to do a macro dose. Is that the case? And do you have that same feeling with the micro dosing, or I'm assuming not? Or can you touch on your approach to that?
Yeah, no, good question. So yes, with the macro dose, you are looking for a patient to kind of have a bit more of an elevated cow score. And I don't remember exactly what those
It's
studies.
13, usually 13.
Okay. So around 13 then. And then, yeah, you just kind of bomb them with the buprenorphine, kind of get it going. With the low dose induction, I have primarily used that when, yeah, we're transitioning a patient. They're not in withdrawal yet. And the idea is just to kind of get them there.
Yeah, I mean, low
Have
dose
you
induction, Jacob, they're not in withdrawal. That's the benefit
Correct.
of it.
Yeah.
They're not in any withdrawal. And like I was saying, typically they continue using their film agonist the whole time you're doing it. And often with fentanyl, that's what happens. They continue
Mhm.
using the fentanyl on the street, the same dose they were using before while you're doing that low dose induction, and you're slowly pushing off the fentanyl from with the butte.
Yep,
have you
exactly.
Have you had much experience with patients having a lot of fear of being thrown into withdrawal, like with the macrodosing? And would that be one indication to lean towards the microdosing?
So I have not had a chance to do the macro induction, kind of in the outpatient clinic. So I couldn't tell you exactly with that. I think it just kind of depends where a patient is, once again, if they are in that true withdrawal or if they are not in that withdrawal. I would say, um, the patients who aren't in withdrawal are probably going to be pretty darn fearful about going into it and having to get into withdrawal in order to get that macro dose. I do hear that pretty frequently, even when we're discussing coming off of like, prescribed pain medications that I've been transitioning people. So,
Yeah, I'm giving a talk on microdosing in a couple of weeks, and that is a major indication when you have people that come in and they've had precipitate withdrawal before and they don't want
mhm.
to go through it again, and that's they're good candidates. The other good candidates are people that are having pain because then they don't really have to go through an opioid free period. You're continuing those other opioids and then adding the bupe. Um, so yeah, but I've heard ER docs lecture at 8 a.m. right, and one was saying as soon as I see first signs of physical signs of withdrawal, I'm giving them 16 of bupe. These are fentanyl users, and it worked really well for her. Um, so it's becoming more and more common to do macrodosing with fentanyl.
We have enough time for one more question or comment. So, Tim, I saw that you had unmuted yourself. Did you want to add anything?
Well, it kind of the answers got came out, but so does it seem that for the patient, it's less traumatic, uncomfortable for them to go the micro dosing route versus the macro, like all other things being equal?
Provided that they are continuing on their full strength agonist, I would say, yeah, that would be less uncomfortable for them. Is it a bit more dangerous? Absolutely.
Right.
Because still taking fentanyl. But yeah, if you do it right, should be more comfy.
Okay. Thanks, Andrew.
Mhm.